inflammation of the parotid glands, which are back here, behind your jawbones, okay? And mumps is a viral infection. It's very risky for the elderly. You get severe decrease of saliva and dehydration. It's usually, if it's not viral, it's called by Staph aureus. Okay, so you'll have the same basic symptoms of infection, inflammation. You'll have swelling, edema of the glands, fever, shiny red swelling of the neck. Okay, so the only treatment you can really do for that is antibiotics and hydration, antipyretics. And once in a while, if the parotid glands do not decrease in size, you do a parotidectomy where they actually incise and drain the neck. Okay. Cellulitis is inflammation of the salivary glands. And as I said, you have two different ones. And it's caused by dehydration, radiation, malnutrition, and calculi. You can actually get little stones that plug up the salivary ducts and causes swelling and inflammation of the gland. Okay? Usually that occurs because of improper oral hygiene. If it's infectious, the two agents that are most likely to be victims of this is Staph A and pneumococcus. Basically all we do for that is the same as with all inflammation, anti-inflammatories, antibiotics. If the glands are really swollen, like some hot soaps to try to break down any calculi. And make sure that the patient is hydrating. That's always the key. If there's a lot of inflammation, you can also give corticosteroids to bring down the inflammation. And then the ciliolithiasis, which is actually calculi formed in the salivary gland. Usually it has something to do with having a high phosphate or calcium count. Okay, they vary in size, but when they plug up, you get swelling of the gland. Sometimes it's painful, sometimes it's not. If it's painful, again, warm soaks is usually the solution. You try to get the gland to actually rupture itself, basically open up and relieve the pressure. Okay, neoplasms are cancers, and we'll be talking about those later. Disorders of the teeth. A dental plaque occurs because of poor hygiene, plaque and caries. Okay, poor dental hygiene, not brushing your teeth, not flossing, which is an important thing from the point of view of healthcare workers, because we have patients in the hospital who are not able to provide themselves with oral care. So it is really our responsibility to help them provide oral care. Using the little swabbies, those little dental plaque swabbies, you know, we call them lemon pops, and just brushing them is not adequate because it does not create the friction to remove actual plaque and caries. You actually have to use a toothbrush, because that's the only way to actually remove the dental plaque and caries. You actually do the 2 minutes like the orthopedic dentist has been telling you for years. Diet can have a lot to do with this, depending on having a nutritious diet, and certainly fluoride. Abscess, dental abscess, usually is the gum line, where the tooth is in the gum line, has food that gets stuck in there, which provides a wonderful environment for bacteria to grow, and gets that nice abscess going. It can be acute, chronic, and it has to do again with using good dental hygiene, brushing your teeth, and flossing regularly. The patient will complain of dull pain. The adjacent structures, they can actually get swelling on the inside first, and then you can actually see swelling on the outside. They can actually also develop a myofever because it is an infection. It is highly painful because the nerve endings, we have actually a higher amount of nerve endings in our gums than we have in like our many other tissues. So it's very, very painful. Okay. Treatment for this, again, start with antipyretics, antibiotics, and if it does not resolve, or if the abscess is too large, then they'll do an incision and drainage, and often they'll have to extract the tooth if it's too infected. Malocclusion is where the teeth are just misaligning. Some people live with that for the rest of their lives, but if they're misaligning in a way that you are not able to masticate the food, it becomes much more of an issue where they may have to see a dentist or an orthodontist and get an appliance to help them align their teeth in better manner. Okay. So how do we promote good oral health? Of course, we're going to brush our teeth regularly, twice a day, every day for 2 minutes, 30 seconds in each quadrant, 15 in the front, 15 in the back. And reduce the intake of starches and sugars to maintain good nutrition. Fluoride, especially in our pediatric population. Refrain from smoking and alcohol. Diabetics, keep their sugars in good control so that they don't have a lot of sugar on board. And regular dental care. These are all the things we would want to teach our clients. We now move on to the lips. Okay, we're not going to do all of these. The biggest one that we just finished talking about in microbiology, of course, is herpes simplex, the canker sore. As that is a viral infection, there's not much we can do in terms of preventing it. It has triggers such as extremes in temperature and illness and fatigue. So we want to teach our client to not to adhere to those triggers. And the only over-the-counter drug that I know that actually works really well is Abreva, but it has to be started when the client is feeling the aura that they're going to get a sore, and usually they'll start to itch long before on the lip line, long before they actually have an outbreak, and if it's applied early enough, it can actually be prevented. For those that have multiple sores, they would have to use an antiviral agent such as Zovirax. Okay. Stomatitis is an inflammation of the mouth. It's usually caused by Candida albicans. It's usually a yeast infection, and it's most commonly seen as an opportunistic infection, secondary to either lots of antibiotic use or corticosteroid use or immunosuppression. That is one of the side effects of oral corticosteroids. So if your patients are taking oral corticosteroid enhancing bronchodilators, that's why it's such an important thing to tell them to brush their teeth and rinse their mouth after they've taken their inhaler to prevent oral candiditis and to keep their inhalers clean and dry so that the yeast doesn't develop on the inhaler that then they inhale into their mouth. Okay? Oral cancer. It's one of our nice up and rising cancers. The biggest risk factor, of course, is tobacco, smoking tobacco. But another one that they have not included, yes, is something, including smokeless tobacco, the chewing tobacco that they like to just put into their lip line and suck on, which is really, really gross. My next door neighbor.
So are you saying that we cannot get oral cancer unless it's
No.
tobacco?
I did not say that at
No,
all.
I'm just-
No.
Okay.
No, this is the highest risk factors, those that smoke and those that use chewing tobaccos, which is smokeless tobacco, because you don't smoke it, you just chaw on it. And that actually has a higher nicotine count than the smoking
smoking,
tobacco.
yes, well,
And you absorb much more because it's directly on the mucous membranes. But those are these two are the biggest risk factor. So no, if you don't smoke and you don't drink, it does not mean that you are absolutely never, ever, ever. There is no such thing as never, ever, ever. Okay. There's an increased incidence in men over the age of 40, and African Americans are highest at risk. Usually,
Oral cancer?
yeah. Usually it's a squamous cell. Usually occurs in the areas of the lips, the lateral tongue, or the floor of the mouth. Okay. There are 3,500 new cases a year, but when it's detected early, there's a 59% 5-year survival rate. So it is a very curable cancer when it is early detected. It's 49% at the 10-year mark. But it's one of the ones that is curable. A manifestation is basically a painless sore that won't heal. So it's alteration in the cells. Any lesion that lasts over 2 weeks and hasn't healed should be looked at and should be biopsied. Okay. It may be red, it may be white, and it sometimes will bleed. Okay. As the condition worsens, secondary symptoms is difficulty swallowing, chewing, or speaking, coughing up blood, and then if it's Mets, you'll see enlarged cervical nodes. If it's metastasized, you'll go into the cervical nodes, the lymph nodes of the neck. Management for this person will depend on the location and size of the lesion, but usually we're going to be talking about surgical removal of the lesion and surrounding tissues, radiation therapy, and chemotherapy. Okay. The surgical procedure is called a hemiglossectomy or total glossectomy. Okay, glossectomy means removal of the tongue. So if we are doing a hemiglossectomy, it will affect speech, but they will still be able to speak. If they do a total glossectomy, they will lose their tongue and they will not be able to speak. That would make me stop smoking instantly, personally. If it has moved into the cervical nodes, they will have to remove the nodes, and that would means doing a neck dissection. And we'll be talking about that as well. Okay, so nursing care, obviously, we're going to do our history and physical. We're going to inspect the palate, the structure of the mouth, and the neck. Okay. Our potential nursing diagnosis would be impaired oral mucous membranes, imbalanced nutrition, disturbed body image, fear of pain and social isolation, impaired verbal communication, risk of infection, and always deficit of knowledge. So what would our goals be for a patient that was having any oral issues? What kind of goals would we teach them what?
Cleaning.
So our goal would be that their oral mucosa would be improved, that their nutrition would be improved, that they would maintain their self-body image, pain relief, identify for those that are having speech and communication issues, identify alternate methods of communication, prevention of infection, and understanding of their disease process. So we would implement oral care, dental care, we would educate, we would encourage fluid nutrition, all that kind of good stuff. And in terms of nutrition, we would make sure that they had adequate nutrition patterns that would provide them calories for their bodies. Okay. Assess their preferences according to their social beliefs and cultural belief systems, and make recommendations upon that. Do calorie counts, and perhaps, and then suggest that they go to a nutritionist for a dietary consult. Okay. Other interventions? Yes.
So the removal of the tongue, that means that they would have to be fed by a tube.
Not necessarily.
That's what I was gonna ask you, how they chew
Yeah,
without the tongue.
that's why I was kind of
Well,
thinking that way.
You don't chew with your tongue, you chew
not chew
with
with
your
tongue, but-
teeth.
I know, but
You move the
tongue.
food, so they would
Yeah.
have to probably, it's a very good question, so I would hazard a guess, and I have not had this kind of client, but they would probably be on a softer diet, because you want to make sure they're not manipulating the food too much. And depending on how much of the tongue they've removed, you probably involve a speech pathologist that the person may need to be retrained in how to eat safely.
Well, what if all the taste buds and everything
Mhm.
like
Yeah.
the slot, all that?
Mhm.
I wonder if they could do a prosthetic.
I've never heard of one. Bring in a beef tongue? Bring in
You
a
know,
beef
I
tongue?
really was thinking about that. Like, I know it sounds stupid, but I was actually thinking.
Yeah.
But it does, I mean, you can definitely imagine that the person who's losing their tongue is gonna have not just nutritional issues from the mechanical, but you're right. If you can't taste the food, you really don't wanna eat. So it has a lot of psychosocial. You have taste buds all over the tongue, so
Yeah.
different areas of the tongue have different
Salty,
taste buds.
sweet, bitter.
Mhm. Unami,
Sour.
sour, and unami, I like that word. Which just means savory. Okay? So these are other interventions, okay? Supports self-body image, encourage verbalization as appropriate, pain. So this patient would be avoiding hot, spicy, and hard foods because they're probably not being able to chew it. Have oral care, promote communication through whatever method possible. may have involved speech therapy, okay? Prevent infection, and again, teach the patient. Okay? This is one of the examples of a total neck dissection that is done if they have to remove the lymph glands. We'll be talking a little bit more about it when we get to tracheal cancers. But depending on the involvement, depends on how much tissue has to be removed. And I'm going to be talking about total neck dissections in a few minutes when we get to laryngeal cancer. Let's see here. Actually, I'm going to talk about it now. Get over it. There's several different kinds of neck dissections. Radical neck is the most intensive. It is done, as I said, in oral cancers as well as laryngeal cancers, which involves the removal of the cervical nodes from the mandible to the clavicle. It removes the sternocleidomastoid muscle, the internal jugular vein, the spinal accessory muscle on the side of the neck. So the person's losing the two very largest muscles, which is the one that controls movement left to right, the big muscle that goes from the back of the head all the way to the clavicle, stabilizes the neck, and the accessory muscle in the back, the jugular vein, and the cervical nodes. It is a very huge procedure. They literally excavated a huge amount of their neck. I don't know if anybody's ever seen somebody post radical neck, but they literally are missing a chunk of their neck. It's quite extensive. I actually saw somebody recently when I was out shopping with my daughter. I was like, ooh, that's pretty serious. And that means that that person's head is less stable. So they're going to have to work the rest of the muscles of their neck to strengthen, to make their head more stable. A modified neck dissection saves one or more of the non-lymphatic structures. So they still take all the lymph on that side, but they may leave some of the muscles and they may be able to leave the jugular. A selective neck dissection saves one or more of the lymph groups and the muscles and the spinal nerve, spinal accessory nerve, which is very important. Okay? So depending on where they find the cancer, how many nodes are involved, depends on how deep they go and how much they remove. Okay?
So they don't remove the whole sternocleidomastoid.
Muscle, yes, they do. In a radical neck, they take the whole muscle and the spinal accessory nerve. Mm-hmm. Yes. Mm-hmm. So it's a huge surgery. If they do a radical neck, it's a huge surgery. All right? So some of the things that we're going to concern ourselves with in terms of our assessment is obviously knowledge of the patient, of the procedure, and the potential outcomes of the procedure. What kind of scarring they're going to have, what they're going to look like afterwards, what plans they've made for this. Assess for potential complications. Postoperatively, the patient will need careful monitoring. The number one thing that we're obviously going to monitor for somebody who's had a radical neck is their airway. Okay? Airway is huge, and breathing. Making sure, because they're going to have edema on the side of the surgery. So we're definitely going to be monitoring that airway until that edema has resolved. We don't want any pressure on the incision site or on their airway, stopping them from breathing. Pain is huge. You know, they're not going to be moving their head very much. It's going to be very painful. Potential bleeding and drainage around any drainage system. And they usually do have a drainage system because, again, we want to try to prevent edema at the surgical site, both because we don't want any tension on the suture lines, but also to decrease the amount of pressure that there might be on the airway. Nursing diagnosis, well, a deficit, of course. Ineffective airway, pain, tissue integrity due to the surgery, imbalanced nutrition, because this person's going to have issues eating for a while, and impaired physical mobility, secondary to nerve and neck, in my opinion. I would be putting both in there. Injury. Okay, so this person's going to be relearning how to mobilize their head. Complications that go along with this would be hemorrhage, a fistula between the esophagus and the trachea, and a potential for further nerve injury, since if they're doing a radical neck, they're involving the spinal nerve. So our goal for this patient, obviously, is to provide them with knowledge, about their treatment plan, potential outcomes, to maintain their respiratory status, to provide them with comfort and relief from pain, to help them with their altered body image, absence of infection. If they've had a graft, that the graft is viable, they have proper nutrition and hydration, effective communication, and absence of complications. Okay, to maintain the airway, number one thing we always do is assess. And we're going to monitor it very frequently. This patient is always going to be maintained in a Fowler's, semi-Fowler's, or high Fowler's position. What is that? What's Fowler's? 90 degrees what? Sitting upright. You want them sitting upright, 45 to 90, okay? Encourage deep breathing and coughing. Again, this is a patient who's not going to want to move around much. Okay, they're going to feel like their head's going to fall off their shoulders, especially the radical neck dissection. Okay, so we're definitely going to concern ourselves about getting a secondary infection, getting a nice little pneumonia, because they don't want to move around, and they're afraid to move their airway too much. Okay, if the patient has a tracheostomy, provide tracheal care. That is not uncommon post-radical neck, that they'll do a tracheostomy to prophylactically to protect the airway. That would be a temporary one until the swelling in the neck had receded, and then they decannulate the patient. But it's very common, particularly in a radical neck. Protect the airway, make sure that they've got one. Okay. Patient education, extent of the nature of the surgery. Obviously, this is a patient that, not that we wouldn't with every single patient, but this in particular patient, because of both the physiologic and aesthetic ramifications, especially the radical neck, that we want to make sure that they have full working knowledge of what they're in for. What the post-op period is going to look like, all the different things that may or may not happen to them, equipment that is going to be involved, what the recovery period is going to look like, all the different activities that need to be done to help them resume independence. So post-op teaching begins at the pre-op time with these patients in particular, especially as it relates to self-care. As it says here, signs and symptoms to report, wound care and drains if they go home with them, diet and medication, and their activity level as it progresses through the post-op period. These patients very often, as I said before, will need speech therapy involved, whether it be to help them to communicate again, or whether, as we said before, help them to relearn how to eat in a new pathway, because if they're missing parts of their tongue, they're going to have some problems. And we'll go through. To make sure that they maintain tissue integrity, we're going to suction carefully to make sure we don't interfere with any sutures. Support the head and neck while moving the patient. Again, depending on the level of their surgery, whether it's modified or radical neck, they're not going to want to move their head. They're going to be in a lot of pain, so we're going to have to help them to move their head when the patient is moving. And obviously, even with these patients, we want them moving as soon as we can get them moving. Assess the wound, assess the dressing, and assess the drainage system. And if they've had a graft, we want to assess that the graft condition is positive, that it's taking. In terms of their nutrition, we want to start the nutritional process, the pre-op period. We talk about different kinds of food that they're going to be allowed to eat and going to be able to eat. Encourage a high density, high intake, quality intake. These people probably are not going to want to have huge meals. We have to make sure that their meals are the biggest bang for their buck. The most amount of calories and the least amount of food, because eating is just going to be a big effort. That may require modification to liquid or soft puree diets. Again, we want to make sure that their preferences are being considered. Oral care does not stop just because they've had surgery, so we want to provide oral care after eating, and if they have a tube, we're going to do the tube feedings. still on page 1 of my notes. Believe it or not. We've only gotten up to the upper part of the gastrointestinal system. Okay, now we're going to move on to disorders of the esophagus. And there are a lot of them. There are a lot of them. Okay. I had some people laughing up here. What is dysphagia? Very simple. Difficulty swallowing, which can be for a multitude of reasons. Why would somebody have a difficult time swallowing?
Because they're not having enough secretion.
Because they don't have enough secretion, sure. That'd be a good one. Why else?
They have stuff in his throat. In your esophagus.
Okay, they have a hole in the esophagus. What else?
They probably have a stroke.
Maybe they've had a stroke, so they don't have good nerve intervention to that area.
Parkinson's.
Parkinson's would definitely be one. What else?
Did someone say a trach already?
Well, a trach is not going to affect necessarily their swallowing. They can still swallow it with the trach, unless it's a fresh one.
They can't chew it.
Interesting that you say that. Patients with Alzheimer's have a tendency to forget how to chew. They literally forget how to chew. Yeah.
Delayed swallowing.
You have delayed swallowers, yeah.
Aspiration.
Aspiration is not actually the swallowing in and of itself. One of the easiest ones that causes swallowing difficulties, you put too much food in your mouth and you didn't chew it. Okay, we're all talking high-tech, big. Sometimes it's, sometimes
Right there.
a cigar is still just a cigar. You know? And sometimes you have to look that simplistically when you're doing your assessment. All right? So dysphagia is simply the difficulty swallowing. So sometimes it's the very first sign of esophageal disease. Odynphagia is painful swallowing. So every time you try to swallow, it hurts. It's an Odynphagia, odynphagia. Okay. And achalasia, or achalasia, depending on how you want to say it, is the absence or ineffective peristalsis in the distal esophagus. Remember I kept saying, your food's still going to be mobilized by peristalsis through the esophagus, but if you have achalasia, you literally, once it gets halfway down, that peristaltic wave stops and food starts to get stuck. Okay? It's a failure of esophageal sphincter to relax in response to swallowing. So literally food's going to get stuck on top of the sphincter. It's plumbing, right? So if you keep putting more food in, but it's not going down, what's going to happen? It's first you're going to get distension of the lower esophagus until finally it comes back up. That's exactly. It's more often seen in people over the age of 40. Okay. And you'll see it with the signs and symptoms before it comes all the way back up. It's called difficulty swallowing both liquids and solids. Pain in the chest, because you're going to feel it getting stuck, and some people will report episodes of heartburn. Sometimes, once it gets to a certain point, it actually will distend the esophageal sphincter, food goes in, but you're still getting these recurring feelings after when you're eating food. So to diagnose it, they'll do a barium swallow, because they'll actually be able to see the distension, CAT scan, endoscopy, and manometry, where they're actually looking at the peristaltic waves. Okay? How do we treat that? Very simply, we tell people to chew their food very fine, to drink fluids with their meals, and we'll give them different medications, such as calcium channel blockers, which decrease esophageal pressure. And believe it or not, they'll do an endoscopy, and they will do Botox. Okay? If it's really, really bad, they'll go in and do an esophagomyotomy, where they cut out a piece of the esophagus and they reconnect it. So they take out the part that is not working properly. Okay. I'm going to move to the hiatal hernia next. What is a hiatal hernia? Anybody know? So you did not have a high protein, low carb diet because you've got the postprandial slump.
getting a high glucose, make you sleepy. So what's a hiatal hernia?
Protrusion of
The opening in the
intestine.
diaphragm through which the esophagus passes becomes a large
Protrusion
part
of the
upper stomach.
intestine.
It's actually protrusion of the what?
Upper stomach.
Upper stomach. Okay? Upper stomach. Diaphragmatic hernia is the protrusion of the intestine into the chest cavity. So you each half correct. There you go. But it is a protrusion, and what happens in hiatal hernia, remember I said that the esophagus goes through the diaphragm, okay, to reach the stomach, because the stomach is actually below the diaphragm. So the esophagus actually has to go through it. So there's an opening in the diaphragm, which is basically a hole, where the esophagus passes through. And in hiatal hernia, what you have is either the upper portion of the stomach actually just protrudes straight up. There's a couple pictures in your book, right there, right here, okay. 1013, where the upper portion of the stomach literally comes up and protrudes above the diaphragm, or it actually segments back. So the esophagus all the way through to the stomach, and then a portion actually like slides back up and gets stuck above the diaphragm. And that's a hiatal hernia. It's not very comfortable. Hold on a second, okay. Occurs more often in females than males. As I said, there's the two different kinds. And depending on how much of the stomach distends up into the esophagus, they give it classifications of 1, 2, 3, 4. Obviously 4 being the worst, where you have a lot of the stomach that's coming back up. It creates heartburn, regurgitation, dysphagia, feelings of fullness in the chest, okay? And then they get reflux when they lie down. That's the big one, reflux when they lie down. The problem is that you can actually perforate and hemorrhage the stomach, which is not a good thing, and strangulation can occur. It's usually diagnosed with chest x-ray if they can see it. Barium swallow, they're actually gonna see the stomach coming back up into the chest where it doesn't belong. Usually it's treated symptomatically by having the patient have smaller feedings with fluids to get the food to move along, not to recline after eating for a minimum of 1 hour, and to elevate the head of the bed. So it's just treated symptomatically. Unless it's like a stage 3 or 4, they don't go in and do surgery where they'll actually pull the stomach down and then tighten that hole in the diaphragm. Okay, perforation. I'm just going to talk about perforation in foreign bodies, and then I'm going to move on. Perforation usually occurs because of a traumatic injury. Most often, it's seen as a gunshot wound or a stab wound, especially if you're up in Rivera Beach, okay? Or due to surgery. You're doing surgery somewhere else and you nick the esophagus. One other way that I've seen an esophageal perforation in the pediatric population is children who walk around with items in their mouth that don't belong there. Pencils is one of them. No, that doesn't perforate. What's the number one culprit? Anybody know? It's one of my biggest bugaboos. Number one item that children walk around with in their mouth. Lollipops. Absolutely. That nice little cardboard stick. Then they fall, they trip, and goes right back. You can get an esophageal and a tracheal tear. Yeah, my children were never allowed to walk around with lollipops. I still don't let them walk around with lollipops. Stay with that lollipop. I don't care that you're 18. Don't care. So children, that's the number one thing is the lollipop. Among adults, for non-traumatic, you know what the number one item is? It's usually this one is in males, not females.
Toothpicks.
Toothpicks.
They always shove things in their mouth.
Yep, they walk around with a toothpick, they trip and fall, boom, back it goes. Okay. Obviously, they'll have persistent pain, followed dysphagia, infection. Infection is the biggest one, and often they'll have hypotension. If it's big enough, they'll get a pneumothorax. So, diagnosed with chest x-ray, fluoroscopy, or barium swallow. Treatment is antibiotics and allow it to heal. And if the tear is too large, they have to do a surgical repair. Foreign bodies, yeah, things that don't belong in your mouth that go down, batteries, pennies, buttons, beads, you name it, Okay, usually the only way to resolve that situation is do an endoscopy, go in and pull it out. And actually with children, what they'll do is, depending on what the item is, they will allow it to go down and watch it pass through the stool, depending on the size of the item. Chemical burns tends to be that they've swallowed something inappropriate. It's more popular among our children and among our elderly population, because they don't know what they're drinking. My cute story on this one, which was not a chemical burn, my husband, we had a little fish tank, and my husband was cleaning the fish tank, so he took the fish out, put it in a cup, and put it on the kitchen counter. And my son came by, took it up, and drank the fish.
It's just laughing about it. Did he feel like wiggling?
He was like, sit out. Down it went.
Oh my God.
That's fine. When your
Totally.
husband came to put it
But it
back in
was
the
so
fish tank, it was- what happened?
No, my husband was sitting there, he was like, Joey, don't. Too late.
Never mind.
It was a colored cup, like, like a solo, like a red, in the
He's
cup. He swallowed it. Down it went.
God, I thought I was just drinking the water. And the fish is
Poor
there.
fish.
It's cool.
Sadly enough, this actually chemically, it did happen that through my church, I know this woman who has a child who's physically and mentally handicapped, and somebody had put bleach in a cup intending to add it to the laundry, and the child did not do it and swallowed it.
Oh,
Yeah, yeah.
I had a patient, she drank pine salt. She was thinking and bubbles were coming out. She was trying to cause suicide.
Yeah, I mean, you have sight patients that drink inappropriate items, yeah.
Like their patients that
Yeah, that
drank
happens.
straight bleach.
Yeah, I had, I once, when I was working, if you had a respiratory therapist come to my unit to borrow a ventilator, and he, this huge, big dude, like football player, was literally, he was in tears. And when when I'm like, what's up? And he's telling me that this father was tired of hearing his baby screaming, so he put bleach in the formula and fed it to the baby.
Oh my gosh. Did the baby?
No,
Oh my goodness.
like,
What?
The
Yeah.
kid in your church is still alive though?
yes, but she had a chemical burn of her esophagus, and which I will discuss it now, because what it will do is it will literally sclerose, or you get first inflammation, and then you actually get swelling of the esophagus, and you can't eat.
What made her brain? What caused the brain to have
She was born with only half a brain,
Oh,
literally.
okay, so it
Yeah, no, she
didn't
was
make
born,
it.
no, she was born literally with half a brain.
Oh, okay, I was.
She thought the bleach caused.
No, it didn't, no, she was born mentally retarded, she had half a brain. So the biggest things is obviously profound shock, febrile and shock. If you can get barium down, you can see the damage. Usually we're doing IV management, pain management. We actually avoid putting an NG tube in because you can actually cause more trauma. Steroids, antibiotics, nutritional support, and very often what they'll have to do is they actually have to do dilation procedure afterward to get the scar tissue off the esophagus so that you can get it to work again. So they actually do a full procedure where they actually use a dilator to, it's called the Buji. So yeah, those are the not good ones. GERD, I'm pretty sure that anybody in this nation who watches TV can see lots of commercial about reflux and GERD, gastroesophageal reflux. My husband and I lives and breathes it. Backflow of gastric content into the esophagus. Very common in children, simply because their esophageal sphincter hasn't gotten the muscle tone yet. So it's very common in children. More common,
Isn't that why they get H. pylori because of the
H. pylori is bacteria that is ingested,
intestinal?
and then it's what causes ulcers, stomach ulcers. It's caused by an incompetent lower sphincter, and it can also be a motility disorder where the food is just not going through fast enough. The incidence of GERD increases through the aging process. So all of us that are getting older every minute or every day have the wonderful hope of actually suffering it. Symptoms: heartburn, dysphagia, regurgitation, hypersalivation, esophagitis, and it can lead to aspiration. which is not good because that will lead to aspiration and pneumonia. Diagnostic tests, first teach people what's triggering it. Usually they'll do a barium swallow. They can do a pH probe test where they actually put a probe down to this pyloric sphincter, above the pyloric sphincter, put it on ground for 24 hours and count how many episodes of reflux you have. And depending on how much is coming through, they decide if you have reflux or not. Okay. So what we want to do is teach our patients, triggers such as, oh, she left the room. Caffeine, alcohol, tobacco, beer, milk, peppermint, spearmint, and carbonated beverages. These are all things that should be avoided if you are a sufferer of GERD. Okay. Treatment for GERD includes weight management. The more obese a person is, the higher the incidence of GERD. Avoid laying down after 2 hours of eating, raising the head of the bed 6 to 8 inches. Medications that are often administered is our H2 antagonists, which is our Pepcid and Zantac, or your proton pump inhibitors, your Prevacid, Protonix, and the new one, Zegrid. Zegrid is one of the new ones that's on the market, which is both a pump Protonix, pump inhibitor, proton pump inhibitor, and sodium bicarb. So it gets rid of the acid really fast because the sodium bicarb neutralizes it, and then it tries to activate your pump. If none of this works, they do a Nissen fundoplication, where they take the top part of the stomach and they literally wrap it around the esophagus to tighten that sphincter to prevent the refluxing. The problem with doing a Nissen is that once it's done, you can't vomit and you can't burp. So that's not good either. Not something that you want to do it just because. Barrett's esophagus is where the lining of the esophagus mucus has been altered. It is associated with GERD because you have, so the esophagus is not meant to have acidic material. So once you've got GERD and you're constantly putting acid on the lower part of the esophagus, those cells are going to alter, and you have Barrett's esophagus. It is a precursor to cancer. The cells are no longer squamous, they become precancerous, and you're in danger of developing esophageal cancer or stomach cancer. Signs and symptoms are that you have GERD and you develop strictures. The only way to find out if you have Barrett's esophagus is to do a biopsy of the lower esophagus, and they do a very long word, esophageal gastroduodecoscopy. Yes, very, very long, so a lot of letters. So in other words, they scope you all the way from the esophagus to your duodenum, okay? And the treatment is depending on the findings. If they find that you have bad GERD, they're going to treat the GERD to try to prevent any further damage. And then they're going to go from there. And the last but not least is if you've had your esophageal, if you've had your Barrett's, or even without the Barrett's, esophageal cancer, 3 times more common in women than in men, higher in the African American population over Caucasian, more so in people over the age of 50, and for once, it is higher in China and Iran. So we are not the highest nation to have esophageal cancer. Why they have it there, I have no clue.
They're heavy smokers in China.
Must be, what?
They smoke a lot in China.
They smoke a lot.
But they
Yeah, I know
A lot
that.
of caffeine.
A lot of caffeine.
Diet.
Well, they usually have a more healthful diet because they tend to have more vegetables, rice, and fish in their diet, so I'm not sure. Okay, basically it's usually adenocarcinoma. Risk factors, as I said, is chronic irritation from GERD, alcohol, tobacco, and having Barrett's esophagitis, chronic ingestion of hot liquids and food, nutritional deficiencies, and cigarette smoking and alcohol, all factors of developing esophageal cancer. Signs and symptoms, dysphagia with solids and liquids, feeling of a mass in the throat, reflux of undigested food, which is different than most reflux because usually in regular reflux, you'll reflux digestive food. The kind with esophageal cancer, you're more likely to be bringing up undigested food because, again, the esophagus is going to dilate. We're not going to open that sphincter, so it's the food that's been sitting there. foul breath, and hiccups, again because of the alterations in the cells down in the esophagus. In the latter stages, sternal pain because it's down low in the esophagus, so it's going to be feeling of pain down here, persistent hiccups, and eventually respiratory difficulty because tumors are now developing and pressing on the lungs. Diagnostic tests for esophageal cancers include X-ray, biopsies, and a PET scan. Treatment is dependent on the staging of the cancer. Radiation and chemo preoperatively is often done to shrink the size of the tumor. And operatively, they'll do an esophageal resection. And the approach may be either thoracic or abdominal. Okay. Depending on the size of the tumor and the location, they may be able to do an esophageal resection with continuity to the jejunum. Otherwise, they'll actually do a reanastomosis to the stomach. Sometimes they'll actually use a low part of the lower colon. So they'll resect the esophagus, the part of the esophagus that is cancerous, take it out, and actually use a piece of the colon to replace it. It has a high mortality rate due to leaking and infection at the anastomosis. And sometimes if they can't treat it because the cancer is too advanced, what they'll just do is palliative care, which is basically pain management, control of salivation. They'll do dilation procedures, they continue nutrition, and they might put a stent in. Okay. So treatment for the achalasia, where you've got tightening, is they'll do a pneumatic dilation, and they'll also do this after chemical burns, where the esophagus will actually shrink in size and you'll have difficulty eating. So they'll actually basically be putting a balloon down the esophagus and they pump it up basically to stretch the esophagus to try to enlarge the size of it. We used to call it a Fuji. And these are the two different hiatal hernias, as I said before. With a primary hiatal hernia, you have a piece of the stomach, which is here, which is coming up through the diaphragm where it doesn't belong, or you can have the esophagus coming way down into the stomach the way it belongs, but a piece of the stomach, the cardia of the stomach is actually coming up into the hole in the diaphragm and pinching off.
That causes a lot of
Pardon me?
Does that cause a lot of
It causes a lot of discomfort and a lot of reflux. I'm not sure about the vomiting part. Okay. This is that resection of the esophagus. They'll actually use a piece of the jejunum or the colon and they'll put it in.
That's a good idea.
Yeah, they'll take out the esophagus that is cancerous. All right, let's take a 5-minute break. Everybody get up and stretch. Go get